Hi, and welcome back to another episode of the Rotator Cuff Expert. I'm Dan Orcutt, orthopedic surgeon, and we're going to talk about the second part of a series about the biceps and how the biceps attaches to the shoulder and what we do when the biceps is injured in the shoulder. And so lots of times when you have a biceps tendon injury, we also have a rotator cuff injury and vice versa. Lots of times when you have a rotator cuff injury, we have a biceps injury. So they're synonymous, and lots of times you'll hear patients talk about, and if you're on any sort of kind of lit serve about biceps and rotator cuff, you're going to talk about, or patients are going to talk about, well, I have a rotator cuff tear and a biceps tendon tear and I have a bone spur and all that kind of stuff, and they're all kind of together. And most people have a lot of these things. Not everybody has everything, but a lot of people have more than just one thing. It's rare to have just a pure rotator cuff tear and nothing else. So when we have a pure rotator cuff tear and nothing else, then we just fix the rotator cuff. But most of the time we have something going on with the biceps, especially if we're looking at people who are going to tear the rotator cuff. People who are going to tear the rotator cuff are going to tend to be a little bit older, 40, 45, 50, 55 on the way up. And so when we get a little bit older, that means there's also some imperfection in the shoulder joint too, a little arthritis maybe, and some labral problems and biceps problems. And so last video, we talked about what a labral tear is, a specific kind of labral tear called a slap tear, a superior labral tear, anterior posterior. And what we do about slap tears, in younger people are different than what we do about slap tears in older people. When we want to talk about biceps tears, we're going to stop and we're going to talk about slap tears. If you want to hear about slap tears, go to the previous video and you can learn about slap tears. But we're going to talk really mostly about biceps and what we do with the biceps if it's injured or damaged in the rotator cuff injured shoulder as well. So when we look at the shoulder, right, we have the biceps comes up through this groove. There's a groove that goes from about here to here, and that groove, again, literally a divot in the front of the humerus, is where the biceps lives, comes up and over and attaches at the top of the socket. The rotator cuff, as we learned before, rotator cuff's up here, at least the supraspinatus is up there. And then there's another rotator cuff muscle that comes across here. That's called the subscap. So supraspinatus, subscap. The biceps goes right in between the both of them to go into the top of the socket. And that's what we call the rotator cuff interval where it comes in, okay? So when we have a rotator cuff tear and we have a biceps tear, biceps where it attaches, right? So on the very top of the socket, the biceps is attached to that socket, and if the biceps is injured, then we have to do something about that biceps injury. Most of the time, again, in older people who have a rotator cuff tear too, if we're gonna fix the rotator cuff, we can't just fix the bicep back where it's supposed to be. People get really stiff. So if we can't fix it, we have to figure out what we're gonna do with it. So there's a few things that we can do with it, and there's few things to understand why we might do something one way in one patient and something another way in another patient. Some of it has to do with the exam before surgery and how much pain they're having and where they're having it. We'll talk about groove pain, and then some of it has to do with what the surgeon is most comfortable with. So for me as a surgeon, what we'll do is we'll look at the biceps and decide it looks too diseased, too injured to stay where it's supposed to be. And so we'll do a biceps tenotomy. And so that's the first option. A biceps tenotomy means you cut it. And when you cut it, it shrinks back because it's attached to the muscle here. It shrinks back and kind of gets stuck in this groove. And so we do a tenotomy, it shrinks back, it's stuck in the groove, and then it heals there. And that works pretty well for a lot of people. Specifically, if we're talking about older people, or for whatever reason, person that would be hard to do something else with the biceps here, but most people probably would do fine with a biceps tenotomy. And we worry a little bit about the deformity because it's going to shorten the biceps. We worry a little bit about the strength, and we also worry about groove pain, which means sometimes people have a biceps problem and the biceps is diseased throughout this groove or diseased here, and so when it slides back into here, you're still going to have pain in the front of the shoulder. So the last thing you want to do as a surgeon, you don't want to fix a rotator cuff, do a biceps tenotomy, and then have to come back later to do a biceps tenodesis, which means attaching the biceps. So depending on your age and in your activity level, and other factors would determine whether or not the surgeon is going to do a tenotomy, a tenodesis. So if we're going to do a tenodesis, we say, okay, a tenotomy doesn't seem right for whatever reason. we're gonna do a tenodesis. Okay, so if we do a tenodesis, there's different ways in different areas to do a tenodesis. All tenodesis means is we're reattaching the biceps in a different place. We're not reattaching it here. We can reattach it in 3 different places, approximately. So this is the pectoralis muscle coming across. It attaches at the very bottom, just below the humeral head. And so you can have a biceps tenodesis where you're gonna do it arthroscopically, which means in the joint right next to where the rotator cuff lives, oftentimes attached to the rotator cuff repair too. You put a little anchor here and you attach the biceps to the anchor, and you may attach another anchor or another suture through the rotator cuff. So you actually attach the biceps on top arthroscopically. Now that's nice because there's not an additional cut in the shoulder, and so cosmetically it looks nicer, and you're gonna reattach it there. You're gonna retension it so the bulge will look nearly normal compared to doing a biceps tenotomy. So that's good, but if we're worried about groove pain, we're worried about pain in here. Well, if we attach it here, the biceps is still attached in the groove. So that sometimes leads us to do a different procedure where we have to make a little incision on the front of the shoulder, right in here, to reattach the biceps below the groove. And if you reattach it below the groove, you hope you eliminate the groove pain. So below the groove, you have to tension the biceps, so we get, again, the deformity relatively normal. And then we reattach it just below the groove. So the groove essentially stops right about there. So we attach it to just below the groove, and there's a bunch of different ways to attach it. Same with up here. Typically some sort of anchor that's gonna secure that biceps to the front of the shoulder, to the proximal humerus. So you can do what this is called a supra-pec attachment. So with tenodesis, right? Because this is the pec. So if it's supra-pec, we put it there. So that works because then we don't have to worry about groove pain. And if I'm doing a biceps tenodesis, I will do this if we have a big rotator cuff tear that we need to fix, because it's pretty easy to reattach it in continuity with the rotator cuff repair, as long as I don't think they're having groove pain. And that's where the pre-op assessment matters, to determine how much pain they're having actually where the biceps is. So that's one. And then if I'm worried about groove pain, then I will do a supra-pec. And that's, again, a little incision here, go in there and make a little hole in the humerus and put the biceps tendon there. Most people are not doing a sub-pec biceps tenodesis these days. You can, there's nothing wrong with it. It's a little bit bigger incision. It's a little bit lower, obviously. So what we worry about here is this is really the transition from the biceps muscle to the biceps tendon, right? So it goes muscle tendon right about here, and then goes tendon all the way up into the joint. And so my concern and other people's concern is that when we do it down here, it's a little bit bigger procedure. The biceps is the transition from the biceps tendon to the biceps muscle, what's called a musculotendinous junction. It's not as easy to secure that. I don't feel quite as good. And actually up in here, if we do it just above the pec, we still have the biceps tendon actually kind of can adhere and heal into the pec, underneath the pec here. So that's a more secure, in my opinion, more secure way to do a biceps tenodesis. So those are the 3 options, actually the 4 options. For option 1, tenodesis, just cut it and we say let it fly and it'll heal. And most people do okay with that, especially if you're not high demand. 2, we do a arthroscopic biceps tenodesis, and that's okay as long as we're not worried about groove pain. 3, we do a supra-pec, and that's good because we get rid of the groove pain because the bicep's not in the groove anymore. And that's good stability, good reliability of being able to find the biceps, and it's in the biceps tendon itself. And then lastly, sub-pec. Now, if the biceps is really poorly diseased throughout the whole thing, then a sub-pec might be better because you may have a better secure fixation there because of the transition zone. If you have a really bad biceps tendon, then it may be better to do a sub-pec. So those are the 3 options. Depending on which one you do will determine what the restrictions are. Essentially, the big restrictions after a biceps tenotomy, biceps tenodesis, is that we don't want to load the biceps. We don't want to make the muscle. We don't want to actively try and load it because that can pull on the repair. Other than that, if we're going to do it in conjunction with a rotator cuff repair, most of the time the rotator cuff repair, the protocol for rotator cuff repair will dominate the recovery of the biceps. And so we won't necessarily have to do a little bit change in restrictions, but most of the restrictions are really going to be about restricting and protecting the rotator cuff repair, less about the biceps. So I hope that makes sense. Biceps tenodesis, biceps tenotomy, and how that relates to rotator cuff. Please like and please follow and subscribe. And if you have any questions or comments, please leave them below. And we'll see you next time for another episode of the Rotator Cuff Expert. Thanks.